In this lecture, we will discuss sinus tachycardia and how it would normally appear on the EKG. Sinus tachycardia is similar to normal sinus rhythm. Both are sinus rhythms, but have varying rates. The sinus beats in sinus tachycardia occur above the normal heart range than normal, okay? So otherwise, everything else should be the same as normal sinus rhythm. So let's go over what we see in sinus rhythm because it never hurts to do some review. So just as the name implies, sinus rhythm starts at the sinoatrial node, or the SA node. You may also hear it referred to as the sinus node. The sinus node is that small structure located in that lateral part of the sulcus terminalis at the junction of the superior vena cava and the right atrium. Okay, it represents the start of the normal electrical conduction system of the heart. So here's our superior vena cava, this is our right atrium, and we have this sinus node that's initiating in our first part of our conduction system. Remember, we have our internodal pathways that come to our AV node. This is a Bachmann bundle here to the left side of the heart in our left atrium. We then have our His bundle that splits off into our right bundle branch, okay, to the right side. Then we have our left bundle branch that has a left anterior fascicle and a left posterior fascicle. Both these fascicles and the right bundle branch then go to these Purkinje fibers that innervate the myocardial cells, and the transmission of the impulse spreads by that means. So as long as you can recall this conduction system in your mind, as well as where the leads are placed, okay, identifying the sinus rhythm on the EKG is really not that difficult. In general, sinus tachycardia is often the result of a medication or a compensatory response of the body to certain conditions that require an increase in cardiac output, such as exercise, hypovolemia, hypoxemia, hemorrhage, or acidosis. Okay, so let's go through our chart here and make sure we don't miss anything. So again, it originates in the sinoatrial or SA node. Okay, that's one of the main things here. The thing that differentiates it is the fast rate. Okay, the fast rate of this rhythm. Some causes, we mentioned exercise can be one. Okay, if you're exercising, you're increasing the heart rate, you're increasing your cardiac output. So in order to compensate for that, the rate goes up. Could be from pain, anxiety, hyperthyroidism. Okay, more thyroid hormone will increase the rate. If you have this hypoxemia, okay, or if you have hypercapernemia, okay, in which you have high CO2 levels, okay, if you have acidosis, if you are septic, if you have fever, hypovolemic from hemorrhage or something, pulmonary embolism, medications, we mentioned beta agonists, sympathomimetics, antimuscarinics, and caffeine. These all can cause sinus tachycardia, okay. Now remember, sinus rhythm, right, in this normal sinus rhythm, and this is pretty much what we have going on here, just a faster rate, is that we have a regular rhythm, okay? Regular rhythm meaning that our intervals, we use our R to R intervals, will be constant throughout, okay? So from each R to R interval, we will see that these are all the same throughout. So this is a regular rhythm. You could do the same thing with the P to P intervals, so one P wave to the next. And you would see these are regular throughout, no irregularity to it, and that's what we see in this sinus tachycardia. So what we can also see is that the rate, and remember this is the differentiating factor, is the rate is above 100 beats per minute in adults. Now again, this is age dependent. Remember, in newborns, these younger children, they tend to have higher upper ranges. Okay, look at that, 170 up to 1 year of age. Okay, 1 to 3 months, 150 beats per minute. So again, you have to go beyond that upper range for it to be a tachycardia. Okay, but when we consider adults, remember tachycardia is above 100, and when we talk about a bradycardia, we look at less than 60 beats per minute in adults. Okay, so again, this heart rate is our differentiating factor from the normal sinus rhythm. In terms of our P wave, again, we're going to have normal sinus P waves. Okay, it's coming from our sinus node. Everything is heading this way. Our P waves will have the same morphology throughout. Okay, no difference in their morphology. They all look the same. Okay, constant morphology, the axis is heading in that direction between 0 and positive 75 degrees. Okay, and because of that, remember where our leads are placed. We have lead 2 here, lead 1. We have V4, V5, and V6. The arrow's heading towards those leads, so they'll have positive upright complexes. AVR sits here. The arrow is going away from it. It should have inverted P waves in that lead. Okay. In terms of V1 and V2, remember it could be upright, inverted, or biphasic. If it's biphasic, remember it's going to be a positive and then negative, going upright positive and then negative going down. Okay. So negative. And remember, the initial portion represents right atrial depolarization, the latter portion left atrial depolarization. That'll be important because V1 is an important lead that we look at when we look at atrial abnormalities. Okay, it's one of the short axis views of the heart and gives us a good idea of what's going on in the atria. All right. Remember, V1 and V2 are sitting over our right ventricle. Okay. This is not a 3D model, but it can still work. Remember, the first vector of our atrial depolarization heads towards them. Okay. As this vector is heading towards these leads, okay, there will be an upright P wave. The second vector heads away from them, and because of that, we will see a negative. Okay. So positive initial, negative terminal deflection. That's normal. Okay. In terms of leads 3 and AVL, again, it varies and it's based on the respiratory cycle as well. Now, one thing I want you to note is when we have very fast heart rates, these P waves, where we can see them here, they actually may be hidden in the preceding T wave, okay? And the preceding T wave would be this one here. So here's a P wave, and they may actually be hidden together. So in other words, you would have imagine a complex. Here's our QRS complex, and then we have something that looks like this and like that. Okay, so what I'm saying here is that we have our T wave here, but this portion is our P wave because things are happening so fast. We have our QRS complex, and then on top of the T wave, we have our P wave falling, and because of that, they call that a camel hump appearance. Okay, notice the two humps there. All right. The T wave and the P wave. This would be the T, and that's a P wave. So just something to be aware of when you have these very fast rates, okay, you know, maybe around 150 or so or even higher, you can see the P and the T wave almost fusing together, okay? Now, in terms of the P wave to QRS ratio, again, just like normal sinus rhythm, you have that 1-to-1 ratio where you have one P wave for every QRS complex, okay? And let's just erase some of this here. So one P wave for every QRS complex. So P wave, QRS, this is our T wave, P wave, QRS, P wave, QRS, P wave, QRS, and you always have the P wave preceding the QRS complex, okay? Now, one thing to note, we mentioned the rate, the differentiating factor above 100. Remember, let's just try to find this rate so you remember how we do so. This is a regular rhythm, okay? So what we can do is find this R wave, find the next R wave, which is this one, and count the number of thick lines between it. 1, 2, 3, okay? So a little less than 3, probably between 2 and 3. So 300 over 2 is 150, which is fast. 300 over 3 is 100. So it's somewhere between 100 and 150, okay? So again, above that 100 range, so this is a tachycardic, a fast rate. Now let's get back to our PR interval, okay? Remember the PR interval, if we draw our complex here, this being our P wave, QRS complex, and our T wave, the PR interval is from the beginning of our P wave up until the start of our QRS complex. So that should be normal, okay, between 120 and 200 milliseconds, 3 to 5 small boxes. The QRS interval should be normal, okay? Everything below here in the ventricles is occurring normally, so that should be between 2 and 3 small boxes, or 70 and 110 milliseconds. There's no grouping and no beats are dropped, okay? So everything is pretty much the same as normal sinus rhythm, okay? The only thing that's differentiating it is this rate here. All right, so let's briefly review what we discussed before we end. So again, sinus tachycardia originates from the sinus node, just as the name implies, but in this case, it's happening at a faster rate. Again, it's a regular rhythm. The rate is above 100 beats per minute in adults. The P wave axis will be normal, okay? You'll have these sinus P waves that have these constant same morphology. The axis is leftward and inferiorly between 0 and positive 75 degrees. The upright P waves in 1, 2, V4, and V6, V5 and V6, inverted in AVR, okay? And then in V1 and V2, they can be upright, inverted, or biphasic. Remember, biphasic, if it is, it's positive and then negative, so, as we saw here. If it's variable in 3 and AVL, okay? So again, 1-to-1 ratio of the P waves to QRS complexes. The P wave is always preceding the QRS complex. The PR and QRS intervals will be normal in duration. There's no grouping and no dropped beats present. Well, that's the end of this lecture. We discussed sinus tachycardia and how it would normally appear on the EKG. I hope you learned something.